All right. So we have the agenda. We have our quote of the week. Today we're finishing up chapter 19, surgical skills 2, interoperative and intermediate postoperative period. Now, we have a couple videos on suturing. I'm not sure if we're going to be able to get to all of them, but whatever video we don't get to this evening, and that's because I really want you guys to have time for your survey. I'm going to put it in the archive section, and it's really just on suturing. Now, keep in mind, suturing is not necessarily in our scope of practice. However, that does not mean that you will not have the opportunity to learn and practice. Granted, I learned to suture in the military, but I have sutured as a civilian at a surgery center under the guise of my orthopod. Again, scope of practice, and it's going to be a lot about comfortability, your comfortability, as well as your team. Okay. But keep in mind, always think scope of practice. Okay. And then we're going to have our poll questions and then wrap it all up. As with every week, we have our quote of the week. Success is no accident. It is hard work, perseverance, and most of all, loving what you are doing or learning to do. As future surgical techs, this quote really reminds us that success, it's not going to just happen. It's earned through effort and dedication. Each skill that you will master, every challenge that you will overcome, every long case that you're going to be scrubbed in. You're investing in your learning, building that foundation. And that's going to be really important as you are such an intricate part of patient care. Yes, it takes sacrifice, as you guys already know, but the love for what you're doing makes it all worthwhile. Remember that every step you take now is going to prepare you for the future where your expertise can actually save lives, and it will happen. It is one of the most, in my humble opinions, a humbling experience. So keep pushing forward. You're capable of greatness. With that, chapter 19, finishing it up. And I love that our last chapter of the module kind of is on just understanding suture. So I will tell you, one of the most challenging parts, even when I went through school, was sutures because there are so many. And it's not just the fact that there's so many sutures, but certain sutures are used on certain types of skin, certain sutures that you won't even bring towards certain types of skin. Certain sutures are going to be for certain layers. The sutures that you use in ophthalmology procedures are going to be different than a suture that you use on a shoulder case. Some surgeons, I still have a surgeon that likes to use needles that do not have a suture attached. So just like if you are someone who sews and you know how we have to thread the needle through the eye of the hole, you do that in his particular procedures as well. And I understand why he does it. Okay. So we're going to talk about absorbable and non-absorbable sutures. We're going to demonstrate suture handling techniques. The one thing I want you to remember, especially when you guys get into module 4, is to breathe, okay? Because you're not going to know every single suture from 6-0 to 3-2-1-0, but you're going to be able to understand as you kind of get into the field, okay? Right now, the most important thing is to understand, why do we suture, right? Well, we're trying to reapproximate skin edges. We want adequate tension so it doesn't dehisce, meaning separate. We want to help with hemostasis. We want to help with controlling that bleeding. Of course, suturing does help in wound healing, and it also kind of helps with wound infection, as well as, make it look not so barbaric and give it more of an aesthetically pleasing scar by that approximation of those skin edges. So, what are we talking about? Okay. Now, I want you to ask yourself, why do you believe it's important for us as surgical technicians to really understand the sutures and the types of sutures? I want you to think about how we as techs can be better prepared. Now, one thing I will tell you, Grabbing sutures is some of the very first things that we do when we're getting ready to set up our case. Where do you think we will locate the type of sutures that the surgeon wants for particular cases? Where do you think that's at? Where can we find that information?
Preference card.
Yes, the surgeon's preference cards. That is our holy grail. That is going to tell us what sutures, how many usually, which ones to have on holds, and which ones that they may grab. Now, suture types, we look at monofilament. Okay, so we're talking about right here. These are made of just one fiber. So if monofilament is one fiber, the multifilament is going to be made of several twisted fibers. Now, with that, those are absorbable. Okay. And you can notice that we have them in both non-absorbable because that's just the suture structure. Okay, we haven't got anything else yet, just the structure. We can have single ones, we can have multiple ones kind of braided. Okay. With that, we also look at the composite. It has a core of one material wrapped in another. Each type is going to affect flexibility and how the body is going to react to the suture. So, again, I don't want you to stress out, but we look at suture size. Okay. What you'll notice is that the smaller number is larger and the larger number is smaller. It's going to be really important as you, we're not even talking about our quiz this week or our final. We're talking about once you get into the field. Okay. Once you get into clinicals, this is going to be stuff that you're just gonna, it's gonna happen. You're gonna know. You're gonna be like, oh, I'm gonna get ready to use a 3L Vicryl on SH. I'm gonna have my AdSense with teeth because we're getting ready to close skin. Okay. Now, again, suture sizes range from 11O, which is the smallest. These are going to be the ones that you're probably going to use in ophthalmology cases. Super tiny sutures, okay? And 5O, which are really thick. Think of big ortho, big spine cases, all right? Now, it's based on the diameter of a single strand. Stainless steel sutures follow the Brown and Sharp sizing system, which we'll get into. We look at tensile strength. We're talking about the amount of force needed to actually tear the suture. And this is going to be influenced by a lot of things like the knot that the surgeon ties, biological environment, and the suture uniformity. Now, sutures with low capillary don't retain moisture or bacteria, and that reduces the risk of infection spreading. Now, stainless steel sutures use, again, that Brown and Sharp size system. Now, you may see a question, what type of suture uses the Brown and Sharp sizing system? You're all going to say, oh, that's stainless steel. Okay. Now, again, tensile strength, because you may see this concept again, is the force required to break the suture. Sutures lose 10 to 40% of their strength when it's knotted. So when we tie a knot, okay? So a lot of times when the surgeon's tying a knot, that's all they're doing is tying the suture. So absorption, how the suture material breaks down in our bodies. Is it absorbable? Is it going to break down over time? Can it be natural? Oh, it can be natural or synthetic. Okay. Because I was going to ask you, but no, of course they can. Non-absorbable, does not break down and remains in the body, can also be natural or synthetic. When we look at the capillary action, okay, right here, the ability of the suture to absorb fluids, which can influence infection risk. So if we have a patient that had an infection, right? Or we think that where the incision is, let's say the cranium, we will probably be less likely to grab a suture that can absorb a lot of fluids because we do not want the risk of infection in the cranium. Does that make sense? Okay. Now, with bioactivity, This is how the body actually responds to the suture material. Is it going to act like it's a foreign body and become red, inflamed, pustulous? Or is it going to, you know, let the body heal naturally? Now, all sutures except metal can degrade when exposed to infection. And that makes sense because the infection is in there doing its little thing, trying to harm the host. Bioactivity is going to be influenced by the suture's actual chemical structure and the patient's condition. So, what I did is broke down a couple sutures for you. Sutures have colors, okay? Absorbable sutures where it's breaking down over time. So, you're going to use surgical gut a lot. We use it a lot in oral maxillofacial and sometimes plastic. Now, it's made from animal intestines and it is available in plain or chromic, and it's treated to resist faster absorption. What you'll notice is once you pull it out of the pack, it is going to be wet and you want to keep it wet. What do I mean? So a lot of times the surgeon will throw a stitch, cut it, hand it back to you. Now with chromic gut or plain gut, you do not want it to dry out because it becomes brittle. So what we normally do is we'll kind of have our irrigation, and as we pass it back to the surgeon, we'll irrigate it so that it won't dry out. When you're doing vascular cases, a lot of times the surgeon will have you moist or, wet their hand. You hear them say, wet my hands. Okay. And as they're tying, they're doing that again because they don't want the suture to break. And it's the best suture for whatever part of the procedure they're doing. And so they need it that way. Now you have your absorbable sutures, and I have them color coordinated, kind of like you see cat gut, and then non-absorbable. We use a lot of nylon. We use a lot of silk. The steel is going to be for your bigger cases. Okay. Sometimes for rib approximation, like if we're doing a big heart case, and we got to bring that heart back to the ribs back together. Now, the one thing you just want to remember is that you have absorbable and you have non-absorbable. All right. Silk, natural material often used for soft tissue. Nylon, okay, or polymade. We normally just say nylon. It's strong, it's flexible. You can use nylon across all surgical surfaces. Proline or polyproline, synthetic, known for its low tissue reactivity, right here. And then again, I mentioned that stainless steel, tendons, bone repairs. And if you think about it, it makes sense because you want something strong to be able to help with any type of reapproximation or fixation in tendons or bones. A lot of times with tendons, we'll use anchors as well. That's a whole nother thing, but just know we want something strong because especially that Achilles tendon, it it does so much for your body. All right. Now, what you see here is we look at the healing. There are variables of suture selection. We have to think about the nature of the tissue. We consider the importance and function that tissue is being repaired. Okay. We also think about healing time. You're going to choose sutures based on how long the tissue is needed to heal. The good thing is, once you've been in a service for a while, you'll already know exactly what your surgeons like and what procedures they will most likely use for what suture. All right. We look at some tissue needs sutures with higher tensile strength just to support them as they heal, i.e. Achilles tendon. We use very strong suture for Achilles. We look at the scar formation. In areas where minimal scarring is desired, your face, cosmetic closures, their finer sutures are going to be used. But do not think that it's just going to be in plastics or maxillofacial. I have a general surgeon who does plastic sutures. And his thing is, even though he's doing these big old cases, he wants to give his patients the most aesthetic. Now, I don't mind because I love watching him suture. But just know that plastic closures are going to take longer because they're trying to reapproximate it to the point where you barely even know that there was an incision. With urinary tract, sutures used here, they have to resist infection and promote fast healing. Materials with low capillary and minimal tissue reactivity are going to be preferred in those high risk infection areas. Let's say you're getting ready to do a shunt replacement because of infection. The normal suture that they would use, they're probably not going to, because remember, there's already infection. That's why we're removing the shunt and replacing it. And with a shunt, you're already drilling into the cranium. Okay. You're pulling it out, pulling out the old shunt. You may even have to retunnel into the abdomen. For skin, again, cosmetic closures, sutures that minimize scarring and are going to be absorbable or non absorbable depending on the need. Now, with the surgical needle, there are distinct parts. All right. You have the sharp end, which is the point. This is what is going through the skin. This is going to be the puncture. The body, which is the main shaft of the needle, that carries the suture. And then you have your eye, which is the hole at the end. Now keep in mind, we we I should say most surgeons are not going to use the stringless sutures, but some still do. Now, surgical needles are going to be made from high quality steel alloy, and it's going to make them durable and inert, reducing tissue irritation. Now, eye needles require manual threading. Again, that's why most surgeons have kind of gone away from it. But again, you may find yourself in a case where you're looking at your needle and you're like, oh, it's just a free needle. And that's what we usually call them. They can be curved or they can be straight. And again, it's going to be on the preference of the surgeon. Don't freak out. You load it just like you would any other suture, except now you have like a little free end. You do want to make sure there's a tag so that when they do throw the stitch, the string doesn't come out and it's just the needle. Okay. But your surgeon, your preceptor is going to definitely make sure if you do find yourself in that situation, you are golden. And if they don't, let us know. Okay. Again, my biggest thing is visualization so you can kind of see. Now, what you see in front of you is some sutures. Okay. Sutures are countable, free strings are not. There's no needle on it. So it's not going to be any harm. But when you are counting, you may have a pack that is multiple. And the chapter talks about multiple detachable needles. In neuro, we have up 2 packs of detachable needles that we keep up on our field because if something goes down, there's a bleeder. We usually have 2 locked and loaded. That's what we say, locked and loaded, ready to go. So that as we're handing one, the other one's loaded. And they usually go in 2s when they're bleeding. So you hand one, they have a scissor already up, they have the pickups, you got your second one's ready to go, and then you're just moving, you're moving fast. Okay. So you count everything. You can't just open up the pack or just show the pack and say there's 8 because manufacturer could have errors as well. So you're literally going to open up that pack like you see. And what we normally do is we take like a pickup or something and we're counting 1, 2, and your circulator's watching 1, 2, 3, 4, 5, 6, 7, 8. Both of you guys see 8 because that's what's going to go up on the count sheet. For your labyrinth, where it's just the strands, what, and it's because I don't want to just be like, this is how I do it. Okay. Because I'm your professor. But once you get into the clinicals, you'll see how a lot of different individuals will load these. Some will have them hanging out on the side of the Mayo stand. Some like to have either a schnitt, tonsil, or right angle, whatever the surgeon's preference is, load it. And what we do is we kind of where that finger is we'll load just the tip so none of it's coming out. So like if this was my clamp, it would kind of go like this. You don't want anything hanging out the side. What this is usually used for is kind of tying a um a vessel. So if they're using a right angle, the right angle will go around the vessel. They can take their pickups and do their knot tie. Okay. But you always kind of check what your sutures are and you verify, trust but verify. You even if your nurse is like, "Oh, I just gave you one," and you look and they may have given you one package, but in that package there is probably 4 or 8. So that's why we open it and verify. Okay. Now, we have what's called a continuous suture, where we throw the stitch and on one end, you will kind of like tie the knot and it just kind of goes through. There are advantages. This is a lot faster. It uses less material because you're not like stopping tying the knot, the knot, cutting it. Stop, cutting it. It's just going through. Okay. But here's a disadvantage. If any point along the suture fails, the entire suture line may unravel, potentially compromising the wound closure. We also have interrupted. This is the one you normally see where they throw the stitch, tie the knot, cut. Throw the stitch, tie the knot, cut. Now, it's individually done and it distributes the tension across multiple points, making it strong and reliable. If one stitch fails, the others remain intact. But the disadvantage is it is more time consuming. It requires more material as each stitch needs to be individually tied. Okay. Now, sutures are used to approximate tissue edges, and that's going to help with healing or, in some cases, like bleeding. We have to be prepared to anticipate when sutures will be needed and pass them in the proper manner. Now, the cool thing is, once you guys get in the field, it's going to be like second nature. You're going to be able to see and know, oh, suit tie ready, let's go. Have the other one locked and loaded, needle driver, scissors to the assistant, or in some cases, you may have the scissors in your hand and they're going to show you how you can still do what you need to do and have the scissors in your hand. And when they need to do it, flip it, cut, and keep it going. Okay. There are some cases where we just cannot close for other reasons. Okay. So we have what's called, so don't look at the image yet, but we have what's called subticular buried sutures. This is cosmetic where here are your skin edges, and we're going to suture right underneath that area to kind of bring it a little bit closer. Now, what this does is it keeps it neat, minimally scarred, it helps with the overall aesthetics. Okay. With the purse string suture, this is going to be what you're going to use to close openings like the anus, stomas, or bowel. The suture is placed around the wound and then tightened to close like a drawstring. So if you ever have one of those drawstring purses, it's the exact same concept, except we don't allow it to open and close. We're going to close it completely and tie it. In ortho, we do a lot of locking sutures. It's a variation of the interrupted suture where each stitch is actually locked into place, reducing the risk of losing or loosening and offering stronger wound support. My orthopod preferred to have his locking stitch on his grafts when we would do ACL repairs. And so when I would prepare his ACLs, that's what I was doing. I would be doing his locking stitch. A lot of times in Achilles tendon, when we're not anchoring it down, and what that is the Achilles tendon has ruptured, meaning it ripped. And what we do is we take some cokers, we pull it down. This is a very, very, very strong tendon. And what you see is anchors. So they may even do the anchor method where they drill and then pull the sutures through and secure it that way, just so that it doesn't tear again. Okay. And it just depends on where the Achilles tendon tore it. Now you can look at the retention sutures. These are going to be heavy sutures that are placed through all layers of the body, often in abdominal procedures where there's significant risk of just wound dehiscence where the wounds can separate. And it's usually after large incisions or where the wound is just under a lot of tension. And then we have bolsters where we have plastic or rubber devices. They're going to be placed under retention sutures. Okay, so you got your retention sutures, but you got your bolster underneath, and they're going to be used in high tension or when retention sutures are needed for additional wound support. So, for whatever reason, they're not able to kind of close this particular case all the way. So, they kind of had extra. Okay. And they're going to continue to bring the patient back. That we're not going to just be like, all right, go about your day, have a great life. We're going to bring the patient back to kind of just monitor, and hopefully the wound will heal to the point where eventually the goal is to be able to close the wound. Okay. Now you're going to hear suture ligate or ligature or a ligature stick. These are sutures used to tie off blood vessels or other structures, often seen in procedures requiring a lot of hemostasis. We're trying to control bleeding. In orthopedic devices, we are securing sutures to bone or tissues. When we do rotator cuff repairs, we use a lot of anchors, especially if it's a laparoscopic or arthroscopic case where we are drilling, we're anchoring, and we're moving that rotator cuff because, again, that is a very strong um, part of the body. Okay. Now, we always answer specific questions. Do we need it to be buried? If so, then we're going to primarily look at cosmetic closures. Is this going to be an abdominal procedure where there's going to be a risk that once we try to close it like this, it could dehisce, meaning open up? If that's the case, then we in our mind know, hey, I'm going to need some bolsters. I may need some retention sutures items ready in the room just in case. Okay. Um, and these are some of the things that we can foreshadow and just have prepared. It's better to have it in the room and not use it, or have it outside the room because anything you bring in, but have it outside the room and not use it than not have it at all and then having your circulator trying to find it. Okay. Now we have our stitches again. Again, continuous single. We talked about the locking. We looked at the purse string. Let's see if I can get this interrupted suture video up for us. We have to watch a commercial real quick, you guys. Sorry about that. Okay. All right. So simple interrupted suture. When you're preparing this for your surgeon, we always load it that way and we watch to see where the surgeon adjusts. Okay. I don't know why the closed captions are on. There are two ways to do single interrupted sutures. What you really can't tell from the video, okay, you can now. Some individuals go through each layer, and I have seen some that try to go straight across. I prefer to take my time and go one side and then go back to the other side. There we go. And there is no sound, guys, just so you know. And then we loop it. I usually go 1, 2, not, opposite way, not, and then the other way. And you're gently pushing down because you don't want dog ears and you don't want, so dog ears is kind of like where the skin kind of bulges over each other. That's one thing you don't want. You'll also notice, I don't know if you can tell from the video, when you're suturing, and I had a general trauma surgeon show me, when you're actually using the needle driver, your fingers are not in the finger holes. You have more control when, and I've tried it. So you have more control when you're throwing the stitch. Now, some individuals still like to put their fingers in the hole, but notice your surgeons, okay? A lot of trauma, They will use the needle driver kind of like a part of their entire body. Okay. Your pickups are again extensions of you, extensions of the surgeon. They're using the pickups to gently lift up that skin edge, pull through, adjust the needle. They are not adjusting that needle with their fingers at all. You're going to have to get used to that as well when you're loading those sutures for your surgeon. Okay. When you see where the surgeon likes the needle the very first time and you're adjusting it, practice adjusting it without kind of using your fingers. If you have to in the beginning, it's fine. Even if you continue, but you want to get in the habit of minimum touching of that needle just to reduce the chance of getting poked yourself, especially if it's been used already to throw a stitch and you're having to adjust. You'll also notice that the knots are all on the same side. That's important. Okay. When they cut, it's at a 45-degree. It's not straight down, it's slightly curved. Again, scope of practice, your facility, okay, and your comfortability. I can't tell you to, if the surgeon says, do you mind doing this? I can't say go do it. It's going to be your own. For me, I was all about it. I was like, what? Okay. My very first time that I sutured was actually on a ship during a medical emergency. So it was a little bit different, a little bit stressful. But when I had the opportunity to kind of really have my surgeon help me, I actually sutured a cranium. A patient, the patient had, I don't even know how they did it, but their scalp had avulsed. And I had the opportunity to kind of suture that. And that was actually really cool. Again, scope of practice, your comfortability. Okay. Now, one of the biggest things about our field is trying to prevent needle sticks. No matter how safe you are, things can unfortunately happen. Do not beat yourself up. Things happen. Okay. Now, needle stick injuries are going to be significant, especially in our field, because you don't want to have any type of bloodborne infection, HIV, Hep B, or Hep C. Surgeons, us as surgical techs, everyone in the staff in the operating room, we know we're at a higher risk of exposure because of what we're doing. We're using needles, we're using sharps, we have knives, we have sharp retractors. Even our bovie tips are sharp. Okay. We also have to be very cautious when handling needles to prevent them from falling or being misplaced. We're using appropriate instruments like our needle holders, and we are avoid passing instruments blindly, meaning you're not looking when you're passing them. Now, the surgeon may not look when they're receiving them because they are focused and they're trusting that, we have each other's back. Okay. We also have to think about selecting the right needle for the tasks, reducing the chances of injury. Again, your surgeon's preference card is going to have that information for you. So it's not going to be where you're like, I've got to figure it out. Me wave my hands and get the magic spell. All right. But if a needle stick does occur, the very first thing, and I have seen this question on the CST exam, different concepts asked. Now, it says if a needle stick occurs, of course, you're going to wash the area immediately with antiseptic soap and water. However, the very first thing you have to do is inform your circulator. And that's for a lot of reasons. Think about it. The case is going. You get stuck with the needle. You can't just be like, I'm out. I got to go. You let your circulator know so they can get a replacement for you. Now, keep in mind, the replacement comes, a count is done, then you're going to go ahead, remove your glove, and wash the area immediately. So when it says wash the area immediately may not be as soon as it happens, you're pulling off your gown and glove. In a perfect scenario, of course, but in the real world and even on the exam, you still have to notify someone first. So just keep that in mind. So you're reporting the injury to a supervisor or medical team because there's going to be some type of follow-up. Now, after a needle stick injury, There are post-exposure prophylaxis or PEP that may be recommended, and that's going to be depending on the type of exposure and your patient type. They're going to test for bloodborne pathogens. That's going to be done relatively easy or relatively early to assess potential exposure and infectious agents. And then, of course, there's each hospital has protocols for immediate treatment and monitoring. Keep in mind that preventing needle sticks is going to be so important for your own personal safety and just reducing the risk of infection transmission during any and all surgical procedures. Okay. Now, we're getting ready to do our case. Okay. We've already handed off our Bovie, our Raytax, our light handles. We've given the surgeon the local. We did our timeout before we did all of that. Okay. And we're mid case. And now the surgeon is asking for a needle. So I grabbed these images from the chapter because I figured it'd just be easier. When we are mounting the needle, which is meaning loading the needle, we're positioning it approximately 0.5 millimeter from the swagged end. That is from the book. If you see a concept asking, where do you mount the needle? You're going to position it approximately 0.5 millimeters from the swagged end. In the real world, you're going to position it however the surgeon likes it. Okay. But per the book, this provides better control while suturing, and that does reduce the risk of damaging the suture material. A lot of times you may have a long suture, meaning there's going to be a string attached. That could be a little bit longer than your normal. Do not cut it in half unless the surgeon says. A lot of our double armed, meaning there's a needle on both ends, we use those in vascular, and the surgeon likes to have both ends. We'll put a pledget, which is like a small little, kind of like a foam that we'll put in the middle, and the surgeon is going to use it because maybe they're trying to work with a vessel or a graft, and so they need both needles attached. Okay. But let's say there's not a needle and it's just a longer suture. You are going to drape the loose end of the suture over your hand to keep it organized and ready for use. This is going to help avoid tangling, and it really does help to ensure that it's easily accessible when it is needed. You're passing the needle kind of like you see. Okay. You're not slamming it in the surgeon's hand this time because there's a needle, but you want to make sure that it does get into the surgeon's hand. You're going to position with the hand of dominance. They're going to teach you in the lab because you load a right-handed surgeon's needle differently from a left-handed surgeon's needle. If you're ambidextrous, you have a little bit of an advantage because you know that you are going to suture with your left like this, and you're going to suture with your right like this. There's a lot of different ways that they kind of give you ways to kind of remember. For me, when I'm suturing left-handed, I happen to be able to suture both ways. The needle has to always point at me. So if I'm suturing left-handed and I'm getting ready to suture, that needle's got to point to me. Doesn't matter if it's right. If I load it right-handed, now hear me out. If I'm loading it right-handed and I put it in my left hand, when I go to suture, that point is not towards me and vice versa. That's kind of how I remember, but your preceptors will have different tricks of the trade. Once you get the lab, they have different tricks of the trade. Okay. So, like I said, once you get to your clinicals, it's like you're going to be grocery shopping. You're going to see what you like, you're going to learn different things, and then you can adapt it to what works best for you. Okay. But making sure you load the surgeon's dominant hand is going to be important. If I'm with a surgeon that I've never worked with before, that's one of the first things I say when they're like suture or they'll say stick, and I'm like, are you left or right? And they'll say right, got you, doc. Okay. Now, proper handling and preparation of the needles and sutures is going to be important because we want it to be efficient, we want it to be safe, and we always want a smooth surgical procedure. So now we're going to cut. If it's just you and your surgeon, you are the cutter. Okay. When cutting the suture, the ends should be short enough to minimize foreign material in the wound, but long enough to ensure that you don't cut the knot out. For cutting sutures, we're going to use sharp, straight Mayo scissors or suture scissors. These are going to provide that clean, precise cut. I have seen concepts on the angle. You turn the scissors at a 45-degree angle for better control and accuracy. Now, for the second part, hope you guys aren't forgot to do my disclaimer. Disclaimer, there's going to be images. Sorry, guys. So now we're going to look at different types of wounds, um, commonly used wound dressing materials, and some type of post-operative wound complications. Now, this is a very, this is more going to be like a amputation, to be honest with you guys, because there's not much that we can save. And you can see the tourniquet is already in place. So we get into wound drains. Now, these are the drains that are going to be placed up on the field, most likely before we close. Your wound vac is definitely, especially when it comes with the passive, with the water sealed drainage, this does not go up until we're almost ready to close. And a lot of lung cases will use these. We have active drains and passive drains. Okay. Now, keep in mind, there are a lot of reasons why there's fluid accumulation. And so we want to make sure we catch everything. Um, we look at the inflammatory process where fluid can accumulate as part of the body's just natural response. There's going to be oozing from some small capillaries. Okay. We always hear that serosanguinous fluid where blood and serum they mix and they accumulate in the wound. Now, if it forms serosanguinous fluid, okay, the fluid itself becomes potential bleeding ground for like microorganisms, and that unfortunately can increase the risk of infection, something we do not want. And that's why we have those drains. The whole purpose of a dressing is to have that barrier from dirt and other environmental contaminants, and that just helps to reduce the risk of infection. We look at wound dressing types. Again, these do not come up, per the book, until the incision is closed. And if you think about it, there's no radiopaque strip on any of this. So if this was to get lost in the wound, how would we be able to find it, right? So it makes sense, per the book. And like, again, you're going to see different things in the field that are safe. It's just we got to buy the book. Okay. So these are some of the dressings. We have ointments that can be put up for eyes, for let's say we do monocryl dressing or monocryl stitch. A lot of times with monocryl, if it's a hidden, we'll do Zeroform on top, Teflon, because the Teflon is not going to stick to the skin and cause irritation. A lot of times we may use Dermabond, which is kind of like a glue. So we'll do the monocryl underneath, usually a running stitch, and then we'll do the Dermabond on top. And with that, you just let it dry because it acts like a glue. Anytime we do staples, you're going to have some type of ointment placed on top and a Teflon. And you'll learn, especially what your surgeon's preference are and the type of dressings that they typically use. We do use a lot of paper tape in some cases. Steri strips, definitely. If we don't do Dermabond, you'll do monocryl steri strips. Um, we may even do this Zeroform here, big ortho cases, like our big knee arthroplasties, hip arthroplasties. We may do our staple, 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 and then slap some Zeroform on there. And then, of course, the big bandages. Okay. Just know that all of these will go on your field per the book after, your cases have, your skin has closed, your counts are done. Okay. Because again, there is no radiopaque strip on any of that. You also have to make sure you understand the phases of healing. The CST specifically, and I know you guys are like, I'm in module 3. It's going to come before you know it. They will ask a lot of different questions on the phases of healing, in particular, like your granulation tissue. When does it happen? When does scar tissue form? The purpose. The purpose of scar tissue is just to close and heal the wound. That's why it's there. Sutures are typically removed at the end of the proliferative phase. You may see a concept like that, which actually happens at the or actually happens once the epithelial cells have kind of like gone in and filled the wound with kind of like that scab, and it has like naturally just sloughed off or came off. Okay. Now, there are conditions that affect the wound and how it heals. Immune system is going to be the easiest to kind of identify. If a weakened immune system can impair the body's ability to fight infection and slow the healing process, conditions like autoimmune diseases or immunosuppressive treatments can really make wound healing that more difficult. Let's say you have a patient coming in and they are coming in for a total joint replacement. However, they've been sick for a while. So those are going to be certain things that the surgeon is going to be thinking about. But there's other things like chronic conditions, diabetes, heart disease, kidney disease, that can also interfere with proper healing by affecting blood flow, immune infection, um, and the body's just overall ability to repair tissue. Smoking as well, that is correct. Once you have diabetes is really big because especially once the amputation starts, unfortunately, um, if they don't get it under control, you go from single amputation to double amputation. We do try to save them, save the limbs. We'll do like thrombectomies and different things like that to kind of get the blood flow back to that. But nutrition's also another one. Poor nutrition, believe it or not, can affect wound healing. A lack of just natural essential nutrients can slow that healing process, especially like if they don't have enough proteins and carbohydrates that are actually necessary for tissue repair, cellular growth, and even energy during healing. Obesity is another one. They're at higher risk for surgical complications because they're going to have increased tension. Once we're doing unless you're doing a bariatric case where the whole purpose is to go in there and depending on which procedure, I've done more gastric bypasses, laparoscopic gastric bypasses, and our patients, they have to lose weight to kind of get that case, but they're still larger, okay, like 400. And so we have a bigger bed, but they are bigger risk if you're doing a big belly case for wound dehiscence because you're trying to have that tension to pull everything back. There's poor blood supply. Adipose tissue or fat does, believe it or not, have a limited blood supply, which reduces the oxygen and the nutrients reaching the wound, and that will slow healing. But not just that, there's respiratory issues. Obesity can cause poor ventilation, respiratory deficiency, and that can actually aid in wound complications like infection or, again, delayed healing. Our older patients, 90s, may experience slower wound healing due to just the reduced skin elasticity, um, slower cell regeneration, and decreased immune function. Now, the way surgery is performed can also, believe it or not, influence healing. Poor surgical technique can lead to infections. Improper closure or tension to the wound can affect the overall healing process. So it's just really important for us to kind of know the different reasons why wound healing can be affected. So, some of the things that you will see in the operating room. Now, eviscerations, this occurs when there is going to be a dehiscence or a wound opening that is more severe. It results in the protrusion of the actual abdominal contents. Okay. They're coming out. Your intestines, like, whoa, I can see it. Your omentum, I can see it. Other organs, I should not be able to see that, right? Evisceration is a medical emergency. It requires immediate attention. These patients are coming past the ED straight to the operating room because we're trying to prevent tissue damage or necrosis. With dehiscence, okay, this refers to just the separation. So let's say that the organs didn't come out. We don't see the intestines, but the skin is starting, the wound edges are still starting to separate. This can occur when the tissue does not heal properly. It is where there's the breakdown of the tissue at the wound margins, but does not include the protrusion of internal organs. So that's the difference. Evisceration, we can see the organs. Dehiscence, we can't. Okay. You may see concepts where they flip it, they may throw it, where dehiscence is where you can see abdominal content. That is false. That is not true. Just remember, evisceration, we see it all. Dehiscence is trying to peek through. Okay. Now, let's say there is an eviscerated wound. They're coming straight to us. If evisceration occurs, they're going to cover, hopefully, the tissue is going to be covered when they come to us. Okay. They're going to try to cover the bowel, cover the omentum. Should be with sterile saline dressing because we want to keep it moist. We don't want it to dry out, which can also lead to necrosis or cell death. We're gonna hydrate the tissue. Once they get to us, got saline, sterile saline. We're trying to get it moist. We've got to get that tissue back into the abdominal cavity and repair the wound. That's why they kind of bypass the ED and come straight to us because we got to get them taken care of. Another thing we have to think of with these type of cases is surgical site infections. Infection at the wound site, okay? It can also delay. Now, you're going to hear seromas or hematomas. Now, seroma is accumulation of clear, so you can kind of see it here, yellow fluid in the wound area. A hematoma is that blood at the wound site. It's going to be because of blood vessel rupture. We talked about dehiscence. We know about eviscerations. You may get scheduled. Me and Trevor are in a case. I'm the circulator because why not, right? And he's going to be the scrub. And the case is we're doing a laparoscopic case, lysis of adhesions. And so we're getting our stuff together. And what are we actually doing? We are, I don't know why I did that, getting rid of these adhesions, scar tissue inside. So the surgeon is going to go in laparoscopically. He's going to hand them all the laparoscopic instruments to blow up the belly. We're going to add CO2 in so that we have a space between the organs and we can actually work. Okay. I'm a circulator. I'm watching on the camera or watching on the screen, and he's handing him like graspers and different things to just separate this kind of like scar tissue or adhesions is what we call it um, in the abdomen. Now, a lot of videos I'm going to share with you guys because I realize there is a lot and we are getting short on time, and I really want you guys to be able to answer or not answer, have time for your survey. We are approaching the conclusion of the module, okay? And again, we really want to hear your experience. I am from the mindset that I can't fix something if I didn't know it was broke. I truly believe that. And I'm all about process improvement. So the easiest way is to ask you guys how you're feeling. You guys are getting ready to take it to the next level in the module, where next module, you're going to hands on, you're going to be in the lab, you're going to be really stepping up, preparing for for your clinicals, which is really exciting. So I'll give you guys 5 minutes to kind of go over that. With that, because we're short on time, your poll questions, I'm going to provide you the concepts, break everything down for you, and it'll be in the live archive. So once this is done, we'll come back, wrap it up, and just keep in mind in that live archive section, you're going to have like the contiguous suture. I'm going to go ahead and put the interrupted suturing in there as well, curving, the OR as well. It's a little song that goes with it. It's kind of corny, but it's cool. I like it. And we'll be back. So you guys have 4 minutes. If you've already answered the survey, I thank you so much. But I do want to give you guys your opportunity to be heard because, in my humble opinion, it's important. And I'll be back. All right. As we are finishing up, it's about 20 seconds left. I want to go ahead and wrap everything up. I do just want to remind you there's like, how many questions did I get for you guys? Hold on, let's just look real quick. So there's 15 questions that I will have for you guys. That is going to just be our extra resource as you guys gear up for this week and the final. Okay. We talked about sutures, we talked about wound healing, we looked at needle sticks, which it is something that we try to avoid, but we're in the operating room. We are dealing with sharps, and things can unfortunately happen. Okay. Some things I want you guys to just make sure you have a good understanding on the types of wound healing, complications in wound healing, i.e., the difference between evisceration and dehiscence. Remember, one, I can see the world. Two, it's just kind of like peeking through. Okay. Also, make sure you understand factors affecting wound healing. We talked about that this evening, as well as sutures and surgical technique. Quote of the week: success is not accident, it's hard work, perseverance, learning, studying, sacrifice, and most of all, loving what you are doing or learning to do. For those of you that are watching this playback, how does the immune response affect wound healing, and what can be done to support it? How does factors like lifestyle, nutrition, obesity impact recovery, and how can providers help? And the last question, what does the body use scar tissue um, to do? And does it mean the function and appearance directly is affected by that scar tissue? Let's talk about that in the discussion forum. What questions do you have for me? None. All right. Next week, I'm going to be prepping you guys for module 4. There is, I believe you guys are still using it. I'm going to check with Miss Christie, who you guys will be going to next module. She was using Incision Academy. If you guys are still using that next module, I do kind of want to just showcase it real quick so you guys can see how it works. If you guys aren't, we're gonna do something else. But we're gonna be getting questions. I really want you guys to come next week to kind of just with ideas really of what you really want me to focus on. Send me your emails, messages, texts, whatever, so that I can kind of get that together. We do have a final Quizlet, final Kahoot. We have the whole gambit, but I really want to make sure that it is catered to what you guys need. Okay. With that, I look forward to seeing everyone who can attend on Wednesday. Good night, everybody.